Welcome to this module on radiological anatomy of the chest or thorax region. In this module, we will look at several normal and abnormal clinical images related to the chest or thorax region and make an attempt to correlate anatomy and radiology. Before we look at these images, let us review how we interpret X-rays. It is important to make an assessment of the exposure that the X-ray has undergone. Is it too white or too dark? An over or under exposure of an X-ray may lead one to make an incorrect diagnosis. It is important to make an assessment of the orientation of the X-ray presented. Am I looking at this X-ray right side up? It is equally important to make an assessment of the position of the patient when the X-ray was taken. Was the patient seated? Was the patient lying down? Was the patient supine or prone? And it is also important to have an idea of the particular view that this X-ray was taken in. What was the direction of the X-ray beam? There are several standard views in radiological practice. Let us review how X-rays are taken. An X-ray tube produces X-rays that strike and cross through the patient to reach the X-ray film. The direction of this X-ray beam might be from the back of the patient through the patient to the front of the patient, as is seen in this example of a chest X-ray that is in a postero-anterior direction, or PA. The opposite of this might exist when the X-ray strikes the patient anteriorly and crosses through the patient and exits posteriorly, that is an antero-posterior or AP view. Thus we have an antero-posterior view when the striking X-ray is on the anterior side first. The opposite of this is a postero-anterior view. A third view is a lateral view, where the X-ray strikes midway between the anterior and posterior directions. Another view is an oblique view, where the X-ray strikes the patient at an angle. And then finally we have some special views, and we will see examples of all of these views in this module and in subsequent modules. Let us now go through the process of making an assessment on the quality of X-ray presented to us. Here we have an example of a chest X-ray. Before we make any clinical interpretations, we must assess the quality of the X-ray. Usually the first thing we look for is whether the entire chest is included. That means from the superior end to the inferior end at the diaphragm, and the right side to the left side. A good landmark guide is the inclusion of the costophrenic angles on the right side here and on the left side, which is cut off from the image here. In this particular case, both the costophrenic or CP angles have not been included completely. A second point to be noted is the exposure. A good guide for this is the visibility of the thoracic vertebra through the heart shadow. The thoracic vertebra should be just visible through the heart shadow. In this particular instance, the heart shadow entirely overlaps and covers the thoracic vertebra. This exposure is not correct. A third point for consideration is the relative rotation of the patient as compared to the X-ray film. A good landmark guide for this is the medial end of the clavicle on the right and left sides. Ideally, these two ends of the clavicles should be equidistant from the midline. In this particular instance, the distance on the left side is much longer than the distance on the right side. There is some rotation of the patient which might make a difference in a clinical interpretation. And finally, we'll look at the level of inspiration. Ideally, chest X-rays should be done in an optimal inspiration, and in such instance, the diaphragm is at the level of the 10th rib. In order to count the posterior ends of the rib, one can go from the superior end and count downwards. This is the first rib, second rib, third rib, fourth, fifth, sixth, seventh, eighth, ninth, and 10th. So the inspiration level in this particular X-ray is optimal. But there are other factors which might compromise our clinical interpretation. Once we are satisfied that the X-ray is adequate for us to make a clinical interpretation, we usually go through a sequence of steps that allow us to make an assessment on all anatomical regions of interest. A good sequence would be to start with the bone and soft tissues, in this instance of a chest X-ray, and one can comment on the clavicles, the ribs, and the vertebral column. One can then make a comment on the diaphragm, the position of the diaphragm, the shape of the diaphragm, the relative height and levels of the diaphragm, and the comparison between the right and left sides. One can make a comment on the costophrenic angles and the pleura, and we will see examples in subsequent parts of this module which will look at abnormalities in each of these sections. One can also then make a comment on the trachea and mediastinum. The trachea is outlined here by the dark shadow because this is filled with gas and therefore makes a darker shadow on the X-ray film, and it is a midline structure overlapping the thoracic vertebra. The mediastinum extends down and includes the heart shadow and blends with the diaphragm here. And finally, one makes an assessment of the heart and lungs. So instead of jumping straight into the hearts and lung shadows and start making an interpretation related to those organs, one goes through a sequence such that one doesn't miss out any important clinical feature. This is an example of a lateral chest X-ray, and it is important to understand that we always think three-dimensionally and we image three-dimensionally in order to look at objects of interest. This gives us good anatomical correlation and good clinical correlation with the patient's symptoms and signs. Let us look at our first clinical case. We are presented with a 45-year-old male who has a history of low-grade fever and cough for 6 months. So it's a long-standing history. And right-sided chest pain for 3 weeks. And this gentleman complains of shortness of breath. A chest X-ray was done for this patient, which is presented here. And we realize that there is something wrong with the right side of the chest. There is a shadow, a white shadow, with a horizontal surface on the superior end of this. This is a pleural effusion in the right pleural cavity, collection of fluid because of inflammation, in this particular case because of tuberculosis, that has filled the pleural cavity and created the symptoms that the patient has presented with. including shortness of breath and right-sided chest pain. The low-grade fever and cough for 6 months is because of the underlying tuberculosis. Let's look at another clinical case. Here we are presented with a 10-year-old child who aspirated a peanut and was brought to the emergency room. A chest x-ray done of this patient, this child, presented us with a picture like this. And there was no foreign body visible. The peanut is radiolucent. Both lungs seemed reasonably well aerated. In this particular instance, the astute clinician requested an X-ray in expiration, which was presented to the clinician like this. The left lung field here appears more lucent than the right side, and the mediastinum and heart shadows have shifted to the right. Usually they are present more on the left side and extend up to the midline. In this instance, they have been shifted to the right. In this particular case, what happened is that the radiolucent foreign body, that is the peanut, was lodged in the left main bronchus, and it acted as a ball valve and created an obstruction such that there was trapping of air in the left lung. Normally in expiration, both lung fields should look like this on the right side. Okay, here's a pop quiz. A clinical case of a 28-year-old male who sustained shotgun injury to his chest. And there was entry wounds which were seen on the chest just left to the sternum. This is the chest x-ray that was presented, and one recognizes certain foreign bodies seen here, corresponding with the shotgun entry wounds just left to the sternum. Where do you think these shotgun pellets might be located? It is impossible to make an interpretation without a lateral film. And a lateral film here shows that these shotgun pellets are situated just beneath the skin. A lateral film is very helpful in giving us three-dimensional or 3D orientation and depiction. Two views taken at right angles to each other, looked at together, gives us the three-dimensional orientation needed. Always think 3D. Let us look at another clinical case. Here we have a 67-year-old male who had a history of high-grade fever for the last 3 days and complains now of cough and hemoptysis. Hemoptysis is bringing blood up with cough. And here is the chest x-ray that is presented, and one recognizes a white shadow in the left lung field, and this is a consolidation, in pathological terminology, of part of the lung, and it happens to correspond to the area of lung called the lingula. And if we look more detailed, each lobe of the lung will correspond to a particular part of the radiological shadow. So the lingula corresponds to an area of the left lung where we will have loss of the left heart border. And we recognize that the left heart border and the area of the consolidation are blurred. Similarly, in other anatomical areas such as the right upper lobe, we will have the loss of the upper right mediastinal border. And similarly, in the left lower lobe, we will have the loss of the left hemidiaphragm. It is not important for you to remember the correlation between the lobes and the different features on chest X-ray. It is important, however, to take home this message that different lobes or different anatomical regions of the lung can correspond to different radiological features. A lateral X-ray of the same patient depicts the consolidation over here, and this overlaps the heart shadow, which is over here. It is also important to note that this consolidation is located anterior and superior to this major fissure, which runs along this line, and the consolidation is anterosuperior to it. Let's look at another clinical case. Here we have a 72-year-old female who has a long-standing history of hypertension and now complains of shortness of breath. Her X-ray is shown here, and she has cardiomegaly, which is an enlargement of the heart. And this is recognized by the widening of the cardiac shadow as compared to the width of the entire chest. The width of the cardiac shadow is represented by the line A, and the width of the chest is measured between the two claustrophrenic or CP angles and is represented by the line B. This is called the cardiothoracic ratio. The ratio between line A and line B is called the cardiothoracic ratio and is normally less than 50%. In this instance, this 72-year-old female patient has a cardiothoracic ratio greater than 50%, which corresponds to cardiomegaly. We can also look at the heart with contrast material, and here are two examples of a X-ray with contrast material. The upper one here depicts the systemic circulation, and the lower one here depicts pulmonary circulation. In this particular instance, a catheter has been put in through a peripheral artery which goes through the left subclavian artery into the aorta and the left ventricle, and a dye is injected which then depicts and delineates the left ventricle, aorta, and its major branches. Such type of contrast material studies are used to visualize those structures which are not visible on plain X-ray. Here we have two examples of coronary angiogram in the left coronary artery and another two examples for the right coronary artery. It is again important to correlate radiology with anatomy. Thank you very much. This brings us to the end of this module on radiological anatomy of the chest or thorax region.